Good afternoon, everyone, and welcome back to the Lusaka Apex Medical University Virtual Clinical Educational Grand Round. My name is Ms. Shinondo, and I'm your host here from Corporate Communications at LAMU. Today's topic is innovative approaches in treatment-resistant depression, bridging evidence, ethics, and emerging therapies. I would like to acknowledge the presence of our professorial team, Professor Njelesani, Professor Lambert, Professor Mudenda, Professor Mwawa, Professor Mwansa, Professor Mulenga, Professor Obeten, Professor Eta, Professor Viemba, Professor Kasonka, as well as Professor Kumar, Professor Kasolo, Professor Gilani, and Professor Emaus. These grand rounds are part of skill set building within our students. Skills such as long case presentation, self-presentation, public speaking, as well as online webinar etiquette. These are presentations for our students by our students. Thursdays are presentations from our MBCHB faculty, where our students will present interesting and/or complicated cases that they experience during their ward rounds. I would now like to invite our moderator, Mr. Lungo, to briefly introduce the topic and begin the presentation. The floor is yours.
Good afternoon. I would love to start with observing on the protocols at this point to invite all the members of the esteemed university that are joining us for this afternoon's grand round. We are from the Department of Psychiatry. We're going to be looking at innovative approaches in treatment-resistant depression. And also on the topic, we're trying to reach the evidence, ethics, and also emerging therapies in the field. So it is an honor to come here today to this grand round, and we also ask and also speak to it that we try and also look at this pertinent issue that's affecting society today, and also we try and discuss and look at the cases that the students are having in their rejection sessions, and also to try and also move to the emerging trends in the field of psychiatry, and also what is obtaining and what needs to be done. So our topic this afternoon is pretty much going to be looking at what treatment-resistant depression is, and at some point we are going to refer to it as TRD, and the aspect is that we're trying to define it from the perspective that fits the setting that we are having this conversation this afternoon. And also we know that it's a burden both at the global, regional, and also at the Zambian level. And quite a number of cases are coming up, and the prevalence keeps spiking. And one of the aspects that you need to also understand is the part where we need to understand to say this calls for clinical agency. And the aspect is that it presents almost 3 times higher suicide risk that most of the patients that are presenting with treatment-resistant depression are facing. And the other aspect is the innovation gap. Where has it left clinicians and also these people that are supposed to be spearheading the field and also trying to bring in therapies, emerging therapies, and also discussing ethics and also the evidence that comes of research in many instances, and also in our psychopharmacology as an aspect. Then the other aspect is that we need to also consider global research when we talk about landmark trials that are being actually propelled and pushed globally, and in many instances, we're going to be looking at the relevance it has also on the aspect of local infrastructure when it comes to the presentation of what is going on. So the aspect that we're actually going to be discussing this afternoon is that we need to understand the causes and also what treatment modalities and management practices are actually going to be employed. And also what we actually need to understand is that the statistics are actually astronomical. And one thing that is centered around this topic is the aspect of us trying to push and push and push, where we need to understand to say we are discussing the importance of patient-centered care and also how to equip physicians and also clinicians in navigating the complex and also cases that are coming on evidence-based and something that is practical. And at this point, you also need to understand why we need to bridge the gap. So bridging the gap is also another aspect that balances cutting-edge science, biomarker-guided therapy, for instance, and also coming up with digital tools for rural settings and also in places that are under-resourced. And one aspect is policy implementation, where we spark a dialogue on integrating novel therapies into the Zambia National Mental Health Policy. So this afternoon, I'd love to call on the students that are actually going to be discussing the topic, and we're going to start with the patient case study, and I'll call on Ms. Chisha that will take on this informative session with the listeners and also the people present.
All right. Thank you so much. Good afternoon, everyone. I'm Chisha Mtana Dainis, a 60th year medical student at Lusaka Avex Medical University. I'm going to be talking about the epidemiology as well as the diagnostic challenges. Before I go further, allow me first to do a case study that was conducted at Chanama Hills Hospital. This is a case study of Mrs. Grace Mwamba, pseudonym, a 42-year-old Lusaka-based primary school teacher who's currently on study leave. She's married with 2 children. Her presenting complaint being, as I quote, "I feel like I'm drowning in darkness. Nothing works anymore." End of quotation. This is a case of a 3-year history of recurrent major depressive episodes with worsening severity over the past 12 years. Treatment trials have been conducted with the following medications. The first line being sertraline, a selective serotonin reuptake inhibitor, which was given for 12 weeks at a dosage of 100 milligrams per day. There was partial response. Second, there was another treatment which also was proved futile. This was a second line of venlafaxine, a selective norepinephrine reuptake inhibitor, which was given for 14 weeks at 150 milligrams per day. There was no response, as I stated earlier. Next, augmentation was done with aripiprazole of 2.5 milligrams per day at 8 weeks. With this one, there was minimum benefit. However, the patients present with the current symptoms, which are anhedonia, insomnia, 10 kg weight loss, suicidal ideation, as the patient states, as I quote, "My family would be better off without me." End of quotation. The patient is currently unable to work and has withdrawn tremendously from social and family roles. Thank you so much. Delving into the definition and scope of TRD. TRD is the failure to achieve remission after about 2 weeks of adequate antidepressants for a period of about 2 weeks at therapeutic dose. Operationalizing pseudo-resistance, we're ruling out the use of non-adherence, suboptimal dosing, or untreated comorbidities using antidepressant treatment history form. At global level, the prevalence starts at 20 to 30%, according to the World Health Organization. However, in diabetic patients, the prevalent rate of TRD stands at 10 to 15%, with cardiovascular diseases such as left ventricular hypertrophy standing at about 21.7 to 44% worldwide. Bringing down to our African continent, the prevalence varies widely with the estimates ranging from about 3.3% to about 9.8% across different countries. With that total population, about 57% of MDD patients are people living with the HIV. From that population, about 85% of pregnant women accounting for MDD. These are figures that should not be left unattended to. In sub-Saharan Africa, however, there is absence of data, but in specific countries such as Angola, it stands at 3.6%, Botswana with 4.7%, Lesotho with 4.8%, and South Africa 4.7%. Looking at the Zambian context, depression prevalence is about 5 to 10%. However, there is limited access to data as data comes in fragmented forms, and there are a lot of resource gaps. There's about 62% of MDD cases. These emanate from traditional healers, as most of our population consult traditional healers before seeking medical attention at mental health hospitals such as Chanama Hills Hospital. Going to the DSM-5 and the ICD criteria, DSM-5 requires about 5 symptoms or more, and these symptoms include anhedonia, weight loss, suicidal condition for at least 2 weeks or more. According to the ICD-11, emphasis is mostly on function impairment, and mostly this is only work absenteeism and longitudinal treatment history. However, for lack of trained clinicians and limited access to structured assessments, neither system is uniformly used in Zambia. There are a number of gaps that are owing to the diagnosis of TRD. Some of the gaps include limited access to labs. These labs are such as the thyroid function test. Ladies and gentlemen, as we know, the thyroid hormone T3 and T4 are not in check. We're not going to have good access or good diagnosis of the TRD. Additionally, CRP also plays a vital role. If the CRP is not checked, especially people with MDD, you find that the CRP is increased. Therefore, if it's not tested correctly or if it's not tested accordingly, we may misdiagnose the MDD. Secondly, we also just psychiatric expertise, especially in the Zambian context. In this regard, we are seeing less than 5 psychiatrists in the million Zambians. Additionally, there is incomplete medication trials due to poor access to early discontinuation. Most of our patients with MDD tend to discontinue treatment owing to the fact that they've gotten better. However, there are also socioeconomic challenges, such as the limited use of measurement-based care and lack of standardized rating scales, such as the PHQ-9, as well as the HAM-D, as well as the MADRS to monitor treatment response. Once these standardized rating scales are put in place, it will be easier for health personnel to diagnose the MDD accordingly and are not going to have cases of TRD. Additionally, we also have inadequate electronic health records. This lacks detailed health timelines, hence making it hard to track how many treatments are offered. Ladies and gentlemen, you agree with me at the rate at which Zambia is, we lack electronic health records. As such, it is very difficult to track the treatment of a particular patient, especially those living in the rural areas. Additionally, we also have pseudo resistance. This is owing to non-adherence driven by stigma, poor health literacy, fear of side effects, incomplete medication trials, cultural barriers such as misinterpretation of symptoms, etc., etc. On zero resistance, you find that most of the patients will not adhere to their medication because China Hills is rated as an insane treating center by most of the population in the country. Therefore, patients that are given treatment from such centers, they tend not to continue and hence stop. Additionally, poor health literacy among Zambians or among the general populace is at an increase. For this, we need community education so as we bridge the gap in terms of poor health literacy so that even the patients that are diagnosed with such diseases are helped to not to go into TRD. Incomplete medication trials, as illustrated, patients usually end up not completing their trials because of what I said earlier, as patients relate Chenama use or any mental health hospital as an insanity treating center. As such, they will do not adhere or complete the medication. Additionally, the cultural barriers, as I stated earlier, mental health conditions are usually misinterpreted as symptoms of spiritual attacks, usually termed as bewitchment. So most of the patients will not seek medical attention or medical treatment from specialized centers such as the China Hills Hospital. So what are the solutions to the gaps that have been found? Number one is community education. Like I said earlier, community education with collaboration to the traditional healers. As I mentioned earlier, mental health is seen to the general populace as something that is linked or misinterpreted to be spiritual attacks. Hence, people prefer going to the traditional healers than seeking medical attention to specialized facilities such as Chanama Hills Hospital. Point of care testing. If what about TSH and therapy kits can be deployed in rural health centers or different health centers, then definitely you are not going to misdiagnose MDD to other ailments. Global partnerships. This will help us in the leverage of the World Health Organization's mental health atlas for service mapping and policy integration. Additionally, employment of more qualified clinicians to enhance proper diagnosis of MND and thus prevent TRD. More qualified clinicians need to be employed. As it stands, like I said earlier, Zambia stands at about 5 clinicians against a million population. So if more clinicians who are specialized in mental health can be deployed in different rural health centers, this will help or reduce misdiagnosis of MDD or TRD. Secondly, also, or last but not the least, increase of mental health institutions countrywide. If mental health institutions can be increased almost in all centers or rural health centers or health centers that are provided by the government, this will help to reach out to the community and the community will be abreast with the information, and this will help to curb MDD as well as the TRD. Thank you so much. The next presenter will carry on with the pharmacological and other aspects concerning the TRD. Thank you.
Good afternoon again, once again. My name is Benjamin Siamogo. I am a 60th year medical student at Lusaka Apex Medical University. And I'll take us through the second part of our presentation, which are the pharmacological advances that have been done so far in pertaining to our topic. So before we dive into the topic, it's very important that we acknowledge some of the studies that have been found, that have been done concerning our topic, which have actually indicated that about 1/3 of patients who are suffering from depression do not respond to the conventional treatment that we are using currently. So it's studies like this really that have prompted more information to be studied on this same topic. Okay. So in order to understand the pharmacological aspect, especially from the Zambian perspective, we try to think about it in a way like from a point of view of where we are right now and where we want to be. An example of fluoxetine, citrulline, and SNRIs. Examples can be Lexacin and Orexin, just to give a few examples. So now, if we try to understand the limitations these classes have, we can also understand why we are where we are. So one of the limitations, the most important one, is that 30 to 40% of patients show non-response for first time use. And there's a delayed onset of about 4 to 6 weeks. So the medication may start working maybe up to a month or two. And also there's also limited efficacy for severe and chronic cases. So now that we've understood where we are as a country, this is where now we want to be. So where we want to be is where now the pharmacological advances that are taking place come in. So the pharmacological advances that are taking place, we can look at esketamine, glutamatic agents, and augmentation strategies. So on esketamine, we can look at its mechanism of action. It is an NMD receptor antagonist. It regulates the BDNF, and its efficacy is within 24 hours, you can be able to see results. So the barriers concerning esketamine, there's a bit of a cost there, 500 kwacha, which is about 14,000 by today's exchange rate, which can tell you a lot that the ordinary Zambian family cannot really afford such medication now. And then there's directly clinical visits, meaning we need more health personnel to actually be looking after these people on a weekly basis. That can also be considered as a very serious barrier to achieving this. Then on the glutamatergic agents, we can look at medications like bupropion, which enhances the transmission of GABA by which enhances the transmission of GABA, and it does a 55% remission in 6 weeks. In the others, we can also look at rapastinel, which is also an NMD modulator. It's currently in phase 3 trials, and there's a 45% response and 25% placebo. Then other honorable mentions, we can put drugs like neurosteroids and inflammation-based therapies. So neurosteroids are allosteric GABA modulators. They are rapid with there's a rapid onset with a 3-day course and with a 55% remission in postpartum depression. On inflammation-based therapies, these are based on the deduction that which has been observed that patients with TRD present with many inflammatory conditions. So this is where monocyclines and NSAIDs come in, and with further development of the personal approach, maybe biomarker-guided trials in future. So that marks really the end of this part for pharmacological advances, since now that we have understood where we are and where we want to be. So at this particular junction, I'll introduce the third speaker to take that.
Good afternoon, everybody. My name is Salome Nangwala. I'm a sixth year medical student at the Lusaka Apex Medical University. At this point, we'll look at the neuromodulation of TRD. So neuromodulation refers to a group of medical therapies that directly alter nerve activity to treat various neurological or psychiatric conditions. In context to our topic TRD, neuromodulation is used when conventional treatments like antidepressants and psychotherapy don't have an effect. Yeah, so we'll begin with the electroconvulsive therapy as the first neuromodulation therapy. The ECT was the first to be introduced as one of the neuromodulation therapies. Yeah, and we'll talk about its mechanism of action, its efficacy, contraindications, and side effects. To begin with, its mechanism of action, this is where an electric impulse is introduced to the brain to create a seizure, which in turn increases the levels of neurotransmitters such as dopamine, serotonin, and epinephrine. So for the electroconvulsive therapy, this one is done via general anesthesia. Yes, and various medications are administered to the patient, like atropine. This is done to prevent secretions during the process. And neuromuscular blocking agents like succinylcholine are also given to prevent contractions and injuries to the patient. Yeah, so this is when in ECT we said this is when we introduce a seizure in the patient, and this will lead to increase in serotonin levels, dopamine levels, and epinephrine levels, which are reduced in a patient with depression. I'll go on to its efficacy. Its efficacy is that 57% of patients respond, and stigma persists due to media myths. And the contraindication for this is increased intracranial pressure. And this is because when we introduce the seizure in the patients, yes, there's increased cerebral metabolism. Yes, so the increased cerebral blood flow to the brain, and also increased demand of oxygen and nutrients to the brain. So when we administer this to a patient that already has an increase in intracranial pressure, these cerebral metabolic events occurring in the brain will also increase the intracranial pressure. So this will lead to very different side effects on the patient. So we don't administer this therapy in patients with an increased intracranial pressure. And for the side effects for this therapy, we have short and long-term memory loss and confusion. I'll go to the next neuromodulation therapy, which is a transcranial magnetic stimulation. Ladies and gentlemen, this one is a non-invasive treatment that uses impulses of magnetic energy to stimulate nerve cells in the brain. Yes, so on this one, how it's done is that there is an introduction of a core on the head of the patient. Yes, for this one, we don't we don't put the patient under general anesthesia like the ECT. For this one, the patient is awake. The patient can be chatting with the medical personnel, and the patient is good to go right after the procedure is done. Yes, so we introduce a coil on the head of the patient, and then a magnetic impulse is sent to the brain. Then we stimulate the nerve impulse, we stimulate the nerves in the brain to produce an impulse. Yes. So this eventually causes increase in the dopamine levels too, the serotonin levels, and the epinephrine levels. And for this one, it targets the dorsolateral prefrontal cortex of the brain, because studies have shown that during depression, this area of the brain, the DLPFC, has reduced activity, and it also plays a role in mood stabilization. I'll now talk about its efficacy. Its efficacy is about 30 to 50% responses, and 20 sessions are required for this therapy at a cost of $10,000. And the side effects of this therapy is headache, syncope, hearing loss, and a seizure is very rare to occur. We'll look at our next neuromodulation, which is the vagus nerve stimulation. So this mechanism works as yes, the mechanism of action is that this is an invasive procedure where there is a surgical implanting of a device under the patient's skin on the left side of the chest. So here there's emphasis on the left side of the chest, because so we target the left vagus, yes, the left vagus nerve, not the right one, because if we target the right vagus nerve, this has more implications on the heart, as the heart is also has a pacemaker. Yes, so we target the left side to reduce the side effects. Yes, so we will place this device on the patient's skin on the left side of the chest, and this delivers electrical impulses to the brain. This in turn also alters the levels of dopamine, epinephrine, and norepinephrine. So this will also stimulate the brain circuits yes, which are dysregulated in depression. Hence, this is going to improve the limbic system, which also plays a part in our mood. So the side effects for this vagus nerve stimulation is hoarseness of voice and coughing, as the vagus nerve supplies the muscles to this. Gives nerve stimulation to muscles that are responsible for the voice, which is the voice box, and also coughing. And also we have a tingling sensation on the implant. Ladies and gentlemen, I should mention that the vagus nerve stimulation is used as an adjuvant. It can be used alone. It's used in conjunction with antidepressant drugs. And the efficacy of this is 20 to 40% responses after 12 months, and surgery costs 20,000 US dollars. Then we go to imaging therapies. We have magnetic seizure therapies. These have 50% remission with fewer memory issues, unlike the electroconvulsive therapy, whose side effect is memory loss. Yes. And the MST has a lower risk of post-treatment amnesia compared to ECT, as I earlier alluded to. We also have the TDCS and the TSCS, which have a low cost and can be used at home, and 25% response in pilot studies. And then we have the neuroimaging, which is the fMRI studies, the TMS targeting subgenual anterior cingulate, which improves precision and outcomes. So in conclusion, no one size fits all, meaning treatment must be personalized. The ECT remains the gold standard for TRD. The transcranial magnetic stimulation and the vagus nerve stimulation are very for moderate TRD. Imaging therapies offer hope, but they need more validation. Thank you so much for the opportunity, and now take it up to the next presenter.
Good afternoon, everyone. My name is Derek Kiri, a sixth year medical student at Lusaka Apex Medical University, and I'm going to be taking you through the psychedelic and other novel agents. To start with, novel agents refer to newly developed and emerging treatment and medications that utilizes a different mechanism of action compared to the traditional psychiatric medications that are used at the moment. Then psychedelics, these are refers to psychoactive substances. It refers to psychoactive substances that alters perception, mood, and cognition. So in this particular presentation, I'll focus on psilocybin, MDA, and esketamine, looking at the mechanisms, trial data, safety, and ethical considerations. Psilocybin, looking at the mechanism, this works on serotonin receptors, particularly it works as a 5-HT2A receptor agonist. It does this by disrupting the default mode network hyperactivity. So the default mode hyperactivity is a group of networks that tend to that are overactive in a depressed patient. Therefore, if we use psilocybin, these default mode networks are disrupted, making the patient to have a positive thought and disrupting the negative loop of thoughts. This was evidenced in a trial that was conducted by Campus Pathways, which is a pharmaceutical company that is based in Britain, that showed that 71% remission in the patients that were administered with the psilocybin. Psilocybin is not just a pill. It is a pill that has to be administered in an 8-hour guided session. Why this happens is because the patient has to undergo psychotherapy so that they can well process their memory and thought. Looking at what we have in Zambia at the moment, this drug is not currently used in our country. This is because it hasn't been approved by relevant boards, such as the Institutional Review Board. The Institutional Review Board in Zambia takes about 18 plus months to approve a research or a treatment. Nonetheless, if we're looking at South Africa, they just take about 3 months, which is a very good fast track framework. So if somebody can actually emulate South Africa and use this fast track framework, we can be on a good track, because looking at depression, have very good statistics, of which a lot of people are having treatment resistant depression, and drugs like psilocybin can do a very good job. Can do a very good job. It is in South Africa. If we're looking at South Africa, this drug is already under trial for HIV, for women who are HIV positive and are pregnant. Therefore, we can say that if all African countries can try to can actually try to review their ethics and approval process, this can actually go a long way in patients who have treatment resistant depression. The next drug is called MDMA. The mechanism of action of MDMA is that it increases the serotonin release. Serotonin is also called a trust hormone. So in these patients, it actually makes them to have trust, especially in their therapists, therefore opening up about their traumatic memories and feel that relief. According to the study that was conducted by Multidisciplinary Association of Psychedelic Studies, it showed that 67% of post-traumatic stress disorder patients attained remission. Another study that was conducted in treatment-resistant depression by MAPS, which is just an abbreviation for Multidisciplinary Association Psychedelic Studies, also showed that 40% of these patients actually responded well. That is to say, most of their side effects were not there anymore after they had taken the drug. The next drug is esketamine. Esketamine is a drug that works on NMDA receptors. Esketamine is a drug that has been approved by the Food and Drug Administration. It's been approved for treatment of it's been approved for use in treatment-resistant depression. If we're looking at global exclusion, 90% of the trial lacked African participants. So as much as this cannot be seen as a problem, it is a problem. Because if Africans are not participating in these trials, how do we know that the Africans are going to respond well to the drugs? Because the culture, we have cultural, biological, as well as social factors that differ from other countries. And these factors have to be considered when a medication is being administered. To make this right, there is a demand to include at least 30% of local participants in the studies that are conducted for and in African populations. And then when we look at safety, there is need to pre-screen for psychosis, especially in populations that do have high use of cannabis. This is the end of my part. I'm going to let Eric present the video.
Good afternoon, everybody. My name is David Simumba, 60th medical student in Lusaka Medical University. In continuation from my colleagues, now I'll take you through one of the most promising yet often underused areas in managing treatment-resistant depression, TRD for short, under lifestyle interventions and digital tools. Moreover, these aren't just add-ons, but rather they are evidence-based biologically active treatments that shift outcomes in both ways. This includes physical exercise, nutrition, digital tools, and biomarker guided therapy. Beginning with physical exercise, we know it's good for general health, but its antidepressant effects are remarkable. For example, we have aerobic exercise that stimulate the release of neurotransmitters such as serotonin, dopamine, and norepinephrine. These are the same chemicals that antidepressants aim to increase. Hence, they improve mood and cognitive function. In addition, physical exercise can also boost the brain-derived neurotrophic factor, the BDNF for short, which enhances neuroplasticity and hippocampal growth, which is essential in reversing structural brain changes seen in depression. Furthermore, exercise also regulates the HPA axis, which is the hypothalamic pituitary adrenal axis, by just lowering the cortisol level that contribute to low mood and anxiety as well as cognitive fog. Hence, it is recommended for about 30 minutes of moderate to intense exercise for 4 to 5 times per week. Moving to the next bullet. Moving to the next bullet. Nutrition, which is nutrition and gut-brain axis. Nutrition plays very important role in managing TRD. Hence, deficiency in nutrition such as zinc, omega-3 fatty acid, B vitamins, and magnesium are linked to depressive symptoms. However, as they are crucial for neurotransmitter signaling. What is more fascinating is the gut-brain axis. Over 90% of serotonin is produced in the gut. When the gut microbiota is imbalanced, it leads to systemic inflammation and other brain signaling. Hence, diet like Mediterranean diet, which are anti-inflammatory and gut-friendly, they show improved mood and cognitive clarity. Moving to digital tools. Digital tools are revolutionizing access to mental health. We have apps like Mindful Zambia and software for applications such as USSD Project, CBT, for example, the Malawi Project. This offers CBT interventions, mindfulness, as well as mood track. Study shows that stimulate the prefrontal cortex activity, helping with emotional control, and the regulates the amygdala nucleus, which is the brain fear center, by mimicking the neurobiological activity of the SSRIs, which are selective serotonin reuptake inhibitors. Studies also shows that drugs also activate the parasympathetic nervous system, reducing cortisol, as well as promoting relaxation. Zooming onto the CBT-based digital therapy, ladies and gentlemen, these target cognitive distortion and also encourage healthy behavior. Imaging study shows that CBT strengthens the dorsolateral prefrontal cortex, improving cognitive function, and it dampens activity on the subgenual cingulate cortex, a region often hyperactive in depression. Now we enter the realm of personality psychiatry, which is the biomarker guided therapy. With pharmacogenomics testing, we can analyze genes such as the CYP2D6 or the CYP2C19 to predict how patients will metabolize specific antidepressant. We also use inflammatory markers like CRP, which is C-reactive proteins, or interleukin-6, which suggests if a patient's depression has an inflammatory component, guiding us on the management. Are we adding on an anti-inflammatory agent or a dopaminergic therapy? Although neuroimaging biomarkers are still evolving, they show potential in predicting treatment response based on the brain network activity. In a nutshell, lifestyle and digital tools are no longer free. They are central to the modern management of TRT. They modify biology as well as they affect neurotransmission. They regulate the stress response and improve therapy adhesion. Importantly, they empower patients to become active participants in their own recovery journey, which is very important. But when used alongside this medication, they represent a truly holistic, evidence-based approach in mental health. At this point in time, in continuation with the topic, I got this.
Good afternoon, everyone. My name is Steven Guadia, 60th student with medicine at Osaka Apex University. Carrying on what my colleagues were on the topic, innovative approaches in treatment-resistant depression, bridging evidence, ethics, and imaging therapies. To begin with, in the context of Zambia, there is very limited data on treatment-resistant depression, TRD. World Health Organization 2023 reported that the prevalence of TRD is about 30% in patients with major depressive mood disorder. And also these patients are at the high risk of committing suicide. We see that this is a very major big problem, but managing it is yet another challenge. It is not a smooth road. And this leads me to what I'm presenting on this afternoon, which is ethical and practical barriers in treatment-resistant depression. Okay, so under that topic, some factors that we have got cost, access inequities, informed consent for experimental therapies, and stigma. So now let's talk about cost inequity. For example, esketamine, it has a yearly cost of over $6,000. That is roughly 170,000 kwacha. As compared to when it is on coverage under National Health Insurance Scheme, it's cost as much as 30 cents per day. Not everybody can afford to get this medication, especially when we look at Zambia, which is a low and middle income country. We can also talk about informed consent. Family members, we have a family integrated model. This is what has been implemented in South Africa. So here, what usually happens is that the patient is not the primary decision maker. The family members come together and they decide on behalf of the patient. This has been shown to reduce the refusal rate by 40%. For example, let me talk about the transcranial magnetic stimulation. It has got adverse effects, one of which is memory loss. Not every patient is going to really accept that, to lose all the memory they've had from childhood until where they are. Next bullet there is stigma. At Serenama Hills Hospital, we saw this patient who had started falling ill in September 2023. but we only got to see him in March 2025. When we asked the parents, why are we seeing this patient now? Their answer was, we were going for breast because we were told this has to do with witchcraft. So stigma has shown to cause delays in treatment seeking because the family, the caretakers are going somewhere else and seeking other cares out there. And this is in line with the report, China survey report of 2023 that reports that 68% of mental illnesses are attributed to mental illnesses. That is why we have to come up with awareness campaigns on radios, on TVs, and on social media. Also, caregivers or parents or relatives of the patient, what they expect when they bring the patient to the hospital is to get the patient in full health. But that is not how it works. At the hospital, we want to stabilize, and then full recovery is a day at home. But in an instance of stigma, where there's so much stigma at home, the patient might not benefit to recover fully because the caregivers, the relatives might give up saying that, okay, it is not working, this is actually witchcraft. So now, what are some policy solutions or policy recommendations that we can adopt so that we can be able to bridge all these gaps that we've seen in the management of TRD? So first there is a mental health parity law. HIV and AIDS has to be covered. So why don't we also cover TRD like HIV? So current national health insurance scheme allocates about 2% for TRD. We can increase that. We can expand funding for research and implementation, infrastructure and equipment, and also training medical personnel. But that's shifting. So we can train in nurses, in TMC or ECT administration, like the Rwanda's 2022 initiative. This is going to, it's more like we're sharing the responsibilities, and there's going to be enough people to do something. Also, we can talk about decentralizing clinical trials across Africa to boost inclusion, visibility, and real-world validity. Not institutional, we have only treatment or health centers localized in one place. At this point, I'm going to invite our moderator to speak. Thank you very much.
Okay, so thank you so much for that insightful presentation. So we are coming towards the end of the presentation by the students, and I check on with what has been presented so far. So the first aspect that we need to understand is that we could look at maybe the aspect of therapy comparison. We've all understood and also heard and learned what has been discussed, which is pretty much the aspect of therapy comparison. And also you need to understand traditional pharmacotherapy, and pretty much after its presentation, the slide comes up. So what we're actually going to be discussing is that we compare traditional pharmacotherapy at the level of SSRIs and also SNRIs. And one aspect is that there is a high non-response when it comes to response rates, which stand at about 30 to 40%, and also delayed efficacy. And the other aspect is that we need to remain with a first-line use or treatment option when it comes in with accessibility. And also, when we talk about psychedelics and also esketamine, one of the rapid action drugs that we have, the first aspect is that there's a particular aspect, and also there are also instances of higher remission rates that stand at about 50 to 70%, 71%, and also with but limited by cost, and also exist. So one aspect that we also got from the presentation was on neuromotivation. So you compare TMS and also ECT. We need to understand to say ECT has superior efficacy that stands at about 50 to 70% response. Then also we've got the cultural stigma that comes with the use of TMS or ECT in our localities and also in our places in Zambia, which in turn also could be impressive and interesting. Then lifestyle and digital tools is another aspect where we consider low-cost options such as websites and also USSD-based cognitive behavioral therapy, which just means working with negation of invasive thoughts and also changing the mindset of your patients. So one aspect that you need to understand is that we use bulk SMS transmission to capture people that cannot get access to the local hospitals that we have. And the next aspect is we require scaling up in many spaces, such as rural places. And the next part also of the presentation was on patient-centered care. So holistic screening, for instance, Mrs. Wamba's case. So then we understand that this case underscores the need to rule morbidities such as hypothyroidism and also pseudo-resistance factor. The next aspect also is cultural sensitivity, where we engage the family and the community, which is quite critical in addressing stigma and also improving adherence by patients. And there are also instances on the regional level, such as the Uganda's initial operations that were actually executed and proved to be effective in the treatment and also management of TRT in under-resourced settings. Then also hybrid models will find biomarkers and also digital tools and predictive methods that help records for tailored care response. And the last part also, which is eminent with novelties and also emerging themes and trends when it comes to treatment, stands at the level of equity and innovation. So when you consider esketamine of psychedelics, we understand to say these are drugs that change how a person's perception or even higher cognition when it comes to perception, their mood, and also affect or how they feel about their condition. So an aspect you also need to consider is that there is a risk when it comes to well-being in terms of the disparity. Look at the high-income countries and also Zambia's median income. How many people can afford treatment that would go largely to about $6,000? And also the other aspect is when it comes to informed consent. In many instances, in the clinics that you guys are actually going to be, and also the clinics that are accessible to most of our patients, the major challenge that has come up in the other studies has been obtaining informed consent. And here we require merely adjusting cultural norms that require frameworks like the South Africa's family mediated model, where there is mediation between the family, the caregivers, or even the providers and the people that are working, and also the patient. And the last part is policy class. So this we understand is more at the level of the ministry and also the aspect of pushing towards actually increasing the budget catered towards mental health within the budget that's given to the Ministry of Health. So this is a part where we need to advocate for quality laws and also decentralized trials, which is quite urgent. And also look at the time that we need. There's an aspect of us trying to actually bridge the gap when it comes to innovative treatments and also emerging trends and traditional treatments that we're accustomed to in the country. And the final call to action will be where we prioritize cost and effective innovations. So for instance, we could work with group ECT. And also the other aspect is where we discuss advocacy for policy reforms when it comes to mental health and also mental health quality and other aspects of task shifting within healthcare providers and fostering of global local partnerships that are actually going to give us fast-track ethical, cultural and active solutions and also mitigating the dilemma that we face in the field and also in treating and also managing treatment-resistant depression. So at this point, I'll open the floor and also ask that Ms. Shinondo takes over with the questions towards what we've been discussing as the clinical decision-making and also future practice at this point.
Excellent, thank you. First of all, job well done, presenters. That was quite detailed, and also thank you to our moderator. Now we would like to do a brief roll call. How many are listening from the various LAMU campus sites as well as your placement sites? Please write down where you're listening from in the chat. Whether you're listening from UTH, Levi Mwanawasa, Kitwe, Kabwe, it is open. Please note that these presentations are for students by students. So one day, yourself may be able to take part in these presentations. So we have 2 people listening from UTH. Wonderful, thank you. We have another listening from Levi Mwanawasa. Teaching Hospital. We have Musonda from our Chalala campus. Excellent, thank you. Do we have any listening from out of town? Any from our Kitwe or Kagwe sites or Chipata? We have Eunice from the Chalala campus. So while the comments are coming in, please take note now, question and answer session is now open. You can either ask your question by typing it in the chat, or you can raise your hand and the floor will be given to you. Please note that this is a learning platform open for everyone. It's not only our presenters who are learning and practicing, but also you who are in attendance. This is your chance to get comfortable with online etiquette, asking your questions and interacting with members from the panel. We have Lawrence Katebe listening from Kagwe. Thank you so much. Please take note. This is your chance to ask whatever questions you have. You can also share comments or observations.
Good afternoon, Madam Moderator.
Good afternoon. The floor is yours.
Okay, so first of all, I want to commend my colleague. Observation from the presentation was initially there was a case study on the lady I should think was 42-year-old, a patient from Chainama, who was tracked down for, I think, depression. It should be MDD. My first question was, I wanted to know whether this patient was being tracked down in relation with the topic at hand in terms of the treatment-resistant depression, or she was given as a case study just in line with MDD. Why I asked so was because I wanted to know at what point we are meeting this patient and what really are we coming to do into her life for us to have quoted her into this presentation. Then my second observation is on the part where there was the issue of policy solution in terms of what our country is able to do. One of the things that we have seen there that Dr. Lungo has highly alluded to is the issue of cost and the issue of decision making. In my view, we seem to see that in our country, most of our patients who we are saying are not in the best state to make decisions, we are depending on the relatives who are also psychologically under trauma the time that they are having their relative being treated, and are not really the best people to make decisions for these patients because most of them seem to lack a lot of information. In my view, I wanted to ask the panel if there is any possibility to explore the issue of investing as a country to invest in the training of mental health workers who are going to, specifically nurses, who are going towards the issue of being community-based. I think it would cost us less if we invested so much into community mental health workers who are nurses. These can help us to track down these patients once they are discharged from hospital, in order for us to bring them into compliance and also track them down easily when they are not compliant to treatment. So I just wanted a comment on those two issues. I thank you, Madam Moderator. Thank you.
Thank you so much, Dr. Loomis, for that question. Um, the case study was actually gotten in line with the topic at hand. Not that the patient grace number was being tracked, but it was just found that it was actually in relation to the topic that we are looking at today. Thank you so much. I hope that answers the question.
So there were two questions for Rachel's people. So the other aspect was government policy. I don't know if you might want to change that or that you know what you guys are actually going to say. So I'd love to hear your views on this point. Sure, Steven.
Thank you very much for that question. Actually, I think a community-based psychological or social mental health focus is going to help. Like as I have said, when relatives or caregivers bring their patients to the hospital, they only expect to get them back in good health. So if maybe we say we have a community-based mental health service that is going to be going around and following up these patients in their homes, in their respective homes, seeing to it that they are offered the best psychological care, they are taken care of and supported in every way, it is going to help them be able to recover and not relapse.
Just to add up, of course, like I mentioned earlier, Zambia stands at chief psychiatrists against the million population. Therefore, if places could be also trained, like you put it, this will help also to go down to sort out the issue of what MDD that we have currently, and it will lessen on the burden to our people that are taking care of these patients. So obviously, we hope that a lot of nurses will be trained so that they help also in trying to attend to these cases in the communities. Thank you so much.
It's really contribute. There was additional response.
We hope that answers your question, Madam Eunice.
Yes, it did. Thank you so much. Thank you.
Okay. When it comes to policy decision or making, what comes out after time, even with the question that Eunice is asking, is that there are a lot of lapses. There are a lot of systemic gaps that even us as either end users or people that are in the practice are not going to have so much even when we try and speak to. Because these are policy decisions that we have to present and also allow for actually even policy decision makers and the ministry or even the executive itself or members of parliament to bet on. So these are conversations that we need to start looking into. And even actually the difference when it came to NHIS, which is the equivalent to NEMA. How much is NEMA going to give towards the cost for TRD? And how many people are actually going to be considered to be having TRD, even when you have the differential diagnosis? To what amount of substance use coming in? To what amount are other comorbidities of TRD influencing what we are getting? And also community health workers. At what point are we going to push for more people to be employed in mental health or under psychiatry in general? So it's something that we guys can start to say this. In our culture, there's this only age or actually in a feeling of emotions that's into this topic, we do not have as much influence as the politicians might have. That would be my humble submission.
Excellent. Thank you. We have a question from Sam. How long was lithium carbonate given as an augment for the antidepressant for it to be said as a minor improvement? With reference to our case, was psychotherapy combined with the antidepressants since our patient is an elder on school leave who might be facing pressure on both the home front and academically to try to find the root cause of her problem. Shall I repeat that?
Yes, you can repeat the question.
For how long was lithium carbonate given as an augment for the antidepressant for it to be said it had a minor improvement? With reference to our case, was psychotherapy combined with the antidepressants since our patient is an elder on school leave who might be facing pressure from both the home front and academically to try to find the root cause of her problem?
To begin with, what was added as an on documentation was it aripiprazole at 2.5 milligrams for 8 weeks. And obviously, in the treatment of mental health conditions, we take a multidisciplinary approach. So yes, the psychotherapy was done. Thank you so much.
So the other aspect that also you need to consider when you talk about the medication and also the treatment modality that was used. Remember to say for TRD, obviously at this point, even in the definition, we are actually alluded to say there were failed trials. There was a first-line treatment, which was sertraline, which is an SSRI, and also there was venlafaxine, which was also administered, and augmentation at the end. So one aspect that you need to understand is that the medical model today has shifted from being biocritical, but we are trying to work with the biopsychosocial model that looks at the three factors, that looks at the biological, social, and also social needs of the patient in this case. So what you need to understand is that with CBT, which one of the presenters had alluded to, we realized to say it works well and it is effective to combine psychotherapy and also combine psychotherapy with the other treatment options that we have. So in this case, the continuation of CBT, which is cognitive behavioral therapy, when you look at the presenting cases on the chief complaint, what she said, she feels like she's drowning in darkness and there's nothing that seems to be working more. So when you look at the negative thought pattern of the patient presentation, you realize to say cognitive behavioral therapy to change your thinking patterns comes in handy. It works well when you start to try and also generate our thoughts and also link up to positivity or optimal outcomes that will come with targeting the specific complaints that have been presented by the patient.
Thank you. Sam, who initially submitted this question. Sam, you have your hand up. The floor is yours.
Thank you so much, Ms. Shinondo. Thank you so much, colleagues, for the well done presentation. My reason of asking, I'm sorry, I had mistaken to say you had augmented with lithium carbonate. I didn't notice it was a aripiprazole, as you have mentioned. The reason I'm asking is because we noted, I had in literature where I was reading, it was saying the best option for augmenting in a case where you are suspecting the patient is might be having a treatment-resistant depression, the first line to give the best option to augment your antidepressant is the lithium carbonate. Yes, the antipsychotic which you have mentioned, the second generation, the aripiprazole can be given, but the best one was the lithium carbonate. So a follow-up question on that one will be, why was it was there any issue like psychotic symptoms which the patient presented, which might have led them to choose the second line antipsychotic other than the lithium carbonate? And for it to be just rent, the reason I also ask the duration is because on lithium carbonate, at least a year should be given for you to say this patient didn't respond well to the combination of the antidepressant together with your augmented lithium carbonate. So for how long, because you have mentioned, you say the antipsychotic was given together with the antidepressant, but it gave the patient, it didn't relieve the symptoms. Like there was no remission to the depression, but there was some relief, which made me curious to say, for how long was it taking? Thank you.
Well, Sam, thank you for that. But I think if the slides to be finished, you'll be able to see the current symptoms of the case study. So one of the current symptoms was anhedonia, insomnia, then also wearables and suicidal ideations. And the other aspect is that severity has been actually worsening, and also over time she's been treated and seen for the last 3 years. So this particular aspect that you need to understand is that there is a possibility, even with the drugs of choice that we actually got to use, we tried to use the drugs cover both aspects actually with in many instances as it would be mood or affective disorders that could present, for instance, treatment modality that we could use for schizo symptoms, the positive symptoms that could present in mood disorders. So the aspect that we could also look into is the suicidal ideations increased, but also later on in the presentation, there are ethical dilemmas about the actual drugs of choice that we use, and also the side effects that stem with what has been described, and also the treatment of choice. And also lithium is also another drug that also consider. And at this point, we just say maybe for this case, we would have considered possibilities of running scenarios for both treatment, for both drugs to be evaluated. And the aspect also is that their rotation is 8 weeks. So most of the cases that they're going to find are cases that they build on over and over, and also the cases that have been actually handled by other physicians and also other students in their rotation during the academic year. So that's another aspect that I could allude to. But so far, these are the drugs of choice that we thought had minimum side effects, and also target the presentations of kind symptoms, and also what was being the chief content together with psychotherapy.
Thank you. If we don't have any other questions, I would like to invite our professorial team. Professor Lambert, welcome. The floor is yours.
Madam Snodo, thank you very much, and I'm thanking the team here, the presenters and the moderator. This doctor, this problem very big, and it requires a lot of effort from everyone. Now, as a university, as a department, please concentrate on this issue. Currently, there's an expression that let's have specialized nurses, specialized clinical officers, specialized doctors. Finally, we should reach that. And the potential of you people who are trained to specialize in this field is very, very important. We have been understaffed on mental health and psychiatry in general, very seriously understaffed. And yet, in the region here, Chainama Hospital was really ultra modern type of training site. It was the main trained people, but very few Zambian doctors have gone into psychiatry. I'm very happy that the number 2 Zambian to train under Professor Howard is here with us, Dr. Amson, Patrick Amson. We have employed him. Let's make use of him to see how we can develop this department into really motivation for young workers like you to train in this field. Meanwhile, the problem is existing and countrywide. So what we should do, my suggestion is that let's use the qualified members of staff. In other words, in our training, we should include mental health as a very important aspect of training even through your department, Dr. Longo, we can have an impact. Why don't we develop, say, short courses? If you develop a short course and you invite nurses, clinical officers, doctors, you have the impact on mental health through Lusaka Apex Medical University, CPD, and short courses. Because we do not have time. People are suffering in the society. And the worst thing that the community is very quick at mentioning witchcraft. Very quick. And even if several people, elderly people have developed dementia. If someone goes out of the house and the memory of what we want to the house has come, these facilities are outside the house, they get lost naked. What happens is that they, wherever the sunrise will come, will find him there or her, they will reach, this is a witch. And they start traumatizing an innocent, demented person. So I would say this is all about mental health, memory affected with age. But some of them, let me tell you, I experienced in 1992 when I came back and I was setting up neurosurgical unit at UTH from October 1991, 16th October. I started working to establish that. What happened is that I was doing carotid angiography as a diagnosis for any space occupying lesion intracranial. And one nurse observed me doing it and making diagnosis of chronic subdural hematomas and board red like that. One nurse said, no, I have an uncle in China. He has been there for many years. I want you to go and examine him. I said, okay, sister, we shall go. We went there. And the uncle was called, is he coming in examination room? And I was observing, he was limping. But he was incarcerated for 15 years. He was limping. I said, oh, let me do neurological assessment. That's why I'm saying neurological assessment. Examine the brain, the spinal cord, the muscles. Why the spasticity on one side? Pupils were equal and reactive, but yet the personality changed. That's why they diagnosed him as mental illness. And I said, you know, because of the finding, because the person had hemiplegia, hyperexia, you know, on one side, let's do a carotid angiography. And when we did, we found a chronic subdural hematoma. And it was compressing on the brain, especially the frontal lobe. And we drove, he was okay, back to family life. He was so impressed. The second one followed the third. What is the job and do that? This is brain health, like when I walked in, I was very happy you are talking of neurotransmitter, like serotonin. It's very important. You must immerse yourself in your investigation. Reactive depression or depression are the two types that I've seen, reactive and I saw endogenous. These are both very serious forms of depression. You should see one case or 2, 4 cases, you will never forget how they suffer. The patients are suffering in the society. But so when we the department and specialized people like Dr. Longo, Dr. Msoni, and all other, we have a team of health worker trainers who are here. Can we use this department to reach about mental health. And we can even arrange that you do provincial short courses. You know, Apex is getting established, for example, our pilot site in Chipata. We should have activities there. We intend to go to other provincial centers. You who are training and with so much knowledge from Dr. Longo and the team, consider specializing, even if you don't specialize fully, but you can be a surgeon, a physician, pediatrician with a lot of knowledge on mental health. It's a major field where I think if we had used this country training at China, where this time we have countrywide staffing among nurses, among clinical officers, and doctors. But what I'm trying to, the quickest entry point is to train the existing staff in health centers, in the hospitals, to take mental health seriously. The family health, history to take, family history, then a proper physical neurological examination. Not for mental health is just across the table, just talking and then making them drive. No, there should be proper examination. I told you the case that was missed. The man lost 15 years of his life because he had a subdural hematoma. They were going to talk about the history of trauma. I'm sure you understand it. And the chronic subdurals are very common among elderly people. And you may think the old man, old woman is depressed. No, he has a vision, chronic subdural. Some of them don't even remember the history of trauma. So we have a lot to do as an institution to meet the Department of Mental Health. Under MBCHB, you are under MBCHB. Please mobilize. Let's try to have an impact as an institution. There are a lot of people who are suffering through mental health. Professor Mudenda is also here with you. Please, Uganda. We have our honorary lecturer, China, and we have to join hands. We have some of your people have visited Kabwe, we have visited Kitwe. So let's mobilize. It's quicker to develop short course. In the institution in Lusaka, and also planning to do short courses in the provinces and in districts to be awareness. Awareness is very important. To fight this stigma thing of early mental health is bewitched. You know, it's a very huge cover, Romo cover, on the people who need help. So to me, I think we should do better. Let's advocate. Let's have diagnosis made at community level and use the existing health center staff, district hospitals. Let's preach about how to make a diagnosis for mental health. I think that's what I can pray for now. But we have to wait. This is the way you start things. Don't lose that. All of you are presented. Have the WhatsApp and continue talking to your lecturer. If you want to understand, when you practice the field, you'll be managing patients better because you have a broad range understanding of human health. Thank you.
Thank you so much, Professor Lambert.
Excellent. Thank you, Professor Lambert. We have one more comment from Madam Eunice before we move on to closing remarks. Very important and insightful additions from Professor Lambert. Let Lusaka Apex Medical University lead the way of short-term retraining of medical staff. Let's also advocate that NEMA funding be invested more into mental health, as Dr. Lungo mentioned. After all, most of our leaders in this country need mental health care by nature of their work. You are our hope, Professor Lambert. Well done, Dr. Longo and the team. Thank you. Now, I would like to invite closing remarks from our presenters team. The floor is yours.
Good afternoon once again, everybody. The professorial team, the deans, the moderator, simply put, or protocol observed. I'm here to simply give a vote of thanks. On behalf of my team, I would like to express our deepest gratitude to all of you for making this event a success. Without you, it wasn't going to be possible. First of all, I sincerely appreciate the professorial team, especially Professor Lambert, for your guidance, wisdom, and support. Obviously, your presence always inspires excellence. Thank you so much. To all the deans, thank you for your leadership and always championing academic growth and innovation. Please continue in the same. Special thanks go to our moderator and lecturer, Dr. Longo, for your skillful and for skillfully steering this session. You made this session insightful and with so much clarity. Your contribution kept the event engaging and on track, both here and online. To my fellow presenters, thank you so much for sharing your knowledge. Thank you so much for your passion and your knowledge. Even after working at a short notice, here we are to make this event a success. Please, like the professor has mentioned, let's keep in touch and continue working as such. To our audience, thank you very much for your time. Thank you so much for your attention, as well as your questions and contributions and feedback. Please, let's continue in the same manner. And last but not the least, the organizers, you're behind the scenes working, make this event a success. Without you, surely we're not going to have this. And to everybody, once again, I would like to thank you all, and let's carry on with the banner and sharing ideas today and continue inspiring everyone out there for the betterment of Mother Universe. Without this, we are all going nowhere. Thank you very much.
Thank you. Well done, team. I would like to invite our moderator, Dr. Lungo, to give his closing remarks.
So thank you so much. It has been an honor to afternoon and some information has been shared, and also about the university, and also through you about the different center academics, Professor Lambert. We would love to thank you for the department and also the presenters team for the continued guidance that you've given to us, and also for being the anchor at the university, and also the beacon of hope on what we as young people in the field are actually going to become. And this is something that we would love to end afternoon with, to thank you so much, and also to wish for more continued conversations around mental health and also medicine in general. So thank you so much. I wish you a pleasant afternoon, and we hope to have another insightful presentation in the near future.
Thank you. I would like to invite from our professorial team, Professor Lambert, your closing remarks, sir.
Thank you very much, Dr. Longo. Can we clap for Dr. Longo? Dr. Longo was the guy, and for me, at my age, I'm thinking these are just the beginner. There's a lot of years to go with this setting. You have chosen the right path. This is where we are lacking most. Maybe we have surgeons, we have internal medicine, obstetricians, not enough, but where we are lacking most. That's where Dr. Longo is, that's where Dr. Soni is, and there's also a few psychiatrists. I think the MLA mentioned that we have critical shortage of psychiatrists. And so, let's make a contribution through you, Dr. Longo. Organize. They were organizing this. Some of them will specialize in your field. I'm sure they are getting interest. But we should entice more and more to think about mental health. People are suffering, you know. And so the society, it's our job to change the perspective, the understanding of mental health by the community. So where people are going to work, have this as in on your agenda. How shall you transform the community? No, no, that there's a mentor. And we need to check the brain. Personality changes. You find somebody changes the personality. And we know the balance of the brain thinking, the brain planning, reasoning, can be affected. These are all neurons in the brain. So we need to interact more. I'm very excited with this presentation. And I'm sure our professor, the VC, is attending graduation ceremony at the university today. So you may know which call. Professor Mawa, I hope he attended to this presentation. Professor Mdena, Professor Dr. Musoni, though all of you, and Dr. Longo, the other Longo, yes. So please unite. My prayer is that through your department, let's try to penetrate on information sharing about mental health. Local in Lusaka, through your department, but we can even plan that we go to provinces where our students are, we start there. Kitwe, we have Tukomavel, we have Maui. So it's not what I'm talking about. We start them here, and a lot of people are going, I'm not that, because a lot of people do not understand mental health. And really, it's a big problem which we will try to have an impact as a university. So let's work together. And I'm sure our central administration, the registrar in Chombe, by the way, we might start building our own hospital in Chombe. If we do, mental health should be mentioned all the time. It should be strong. And Professor Mdena is the big advocate that whatever is done we are doing, one of the major departments should be mental health. And we can look after our people well if we have trained the mind. By so doing, I think God will appreciate our efforts, will bless our efforts. So I have seen how people are suffering just from one case, but this is the depression, doctor. Now prepare for schizophrenic cases. There are also many. And I hear alcohol is contributing heavily on the cases admitted in China. So all this is the holistic approach is to look how can we do to cut alcohol damage to the brain. The neurons are getting damage in young people. So how can we do it as a department to explain to people that if you take so much beer, this is what happens to your brain. And the depression is one of them, schizophrenia is one of them, psychotic personality changes is one of them, you know. So we have a lot of work to do. I pray that you remain united. Like you in this group, build more groups like this so that we are developing a team to look after our people well. God's people need your expertise. Thank you very much.
Thank you, Professor Lambert. We have now come to the end of today's virtual clinical educational grand round. This has been deeply insightful. Job well done. To our presenters team, excellent. Please take note that once this recording is stopped, please make your way out of the boardroom outside of outside of the campus building so that we can capture your portrait, as this is part of building a legacy, a LAMU legacy, with our students in collaboration with our teaching staff and our professorial team. Later on, this recording will be uploaded onto our YouTube, as are all of our virtual clinical educational grand rounds, as well as the other presentations. For those who are not aware, Mondays are pre-medical, Tuesday preclinical, Wednesday research, Thursday grand round, this is faculty of NBCHB, and Fridays it covers pharmacy, nursing, as well as from health sciences. Well done, everyone. We have come to the end of today's presentation. Thank you and enjoy the rest of your day.